Thank you, Chairman Scott, Ranking Member Gillibrand, for holding this hearing, and welcome to two of our witnesses that are from Florida for traveling up here and braving the ice on the ground. I know you wish you were back with the palm trees and flamingos. I do too. Welcome. This is such an important topic for our country, especially Florida. We have so many seniors in our state. Some refer to us as not just the Sunshine State, but the Silver State. So discussing how we're going to provide efficient, quality health care is so important. And so this topic is of great importance and particular interest to me. Florida has some of the best hospitals and providers in the country. We have world-renowned care, education, and training. We're so proud of these accomplishments, but we know they're only possible because we have hardworking Floridians that have trained in healthcare and are part of our healthcare structure and show up to work, rain or shine, no matter what's happening. Nationwide, the healthcare industry employs over 17 million people, making it one of the largest employment sectors in the United States. So it is understandable that we need a large healthcare sector and those that will work in this industry. But so much of that economy is tied up in billing, administration, and regulatory compliance, and physicians are increasingly forced to spend nearly twice as much time on administrative work as they do in providing patient care. I hear from Floridians all the time what they're experiencing on the job in these healthcare careers, and it's grinding, it feels burdensome, it's challenging, and I think that is probably why a recent Mayo Clinic study found that 57.1% of physicians said they would choose to become a physician again, down from 72.2% just 5 years ago. With endless prior authorization requests, sometimes combative patients, extreme working hours, it's no wonder that many providers step away from their traditional practices to transition to direct primary care practices, also known as concierge care. Many of these practices allow physicians to see patients for longer, avoid cumbersome administrative processes, all while delivering a higher quality experience and giving doctors more time to live their lives. We expect that segment of the healthcare industry to grow to nearly $36 billion by 2030. And while there is a lot of good with that, and I certainly understand why there is that transition, we have to recognize that the exodus of providers from the mainstream healthcare system is a symptom of an underlying problem with that traditional system. And we as a government have to figure out why that is. I mean, it's no longer a free market in the healthcare system. Government has gotten so involved and so regulated, and we require so many things. Some seem nonsensical, like making you move to a different computer system when yours is working just fine, where you have to maintain 2 computer systems. Unbelievably wasteful, and it sounds just like the government. But we are no longer a free market in our healthcare. I mean, supply and demand in healthcare is not driving costs anymore, and this is why we're seeing costs drive through the roof. This is why it's so taxing now on consumers of healthcare. And I don't blame this mass exodus of people trying to move into what healthcare used to be, providing care to patients in a way where you feel like you have a relationship with them, you can spend time with them, high quality, maybe even cost efficient. So I'm supportive of that, but I am very nervous that concierge care or even direct care outside this, what we would now call the traditional healthcare or mainstream healthcare system, might not be accessible by everyday people who might not have a really, really high income. I worry about that. And obviously, as we're seeing this mass exodus from the profession in general, I think we're going to have a projected shortage of 140,000 physicians by 2038. So we're seeing a mass exodus of physicians, period. We have a mass exodus going into this more direct or concierge care. So I'm really worried about what happens for everyday Americans that might not be able to afford that direct care. And I think this is a great topic for us to talk about because I really think what has driven that is this just crazy, over-regulated, nonsensical approach by government and the more we become involved in healthcare, the more and more complex and out of control and chaotic and unmanageable, not working for physicians, not working for consumers, it becomes. So, Mr. Gross, Dr. Gross, thank you for being with us. Congratulations on a successful career. I wanted to ask you congratulations on all that you have been able to do to navigate around what we in government have created in the traditional healthcare system, but what would be your recommendations from where we find ourselves with a rapidly declining physician population, and out of that, add to it those moving out of a healthcare system that is more traditional, that many use government services or government assistance to access? What would be your recommendations for those of us on this committee to make sure that healthcare is not only quality, but cost efficient for Americans?
Thank you, Mr. Chair. So a lot to unpack in the statements there. I think one of the first things that I'd like to do is just clarify a little bit between concierge medicine and direct primary care, because concierge medicine typically does charge an access fee and then bills a fee for service to a third-party payer, whereas the direct primary care charges a subscription fee and everything's included in that. So there is a difference in the price points.
Different in way you charge.
Different in the way you charge and different what's included. So we don't bill. It's not like a fast pass at Disney World, where you pay for access. That's more of a concierge model. But so moving past that, I would say that a physician that leaves practice because they're overburdened and they have moral injury sees precisely 0 patients. So if you're forcing somebody out of practice because of the complexities of it, then you're not comparing it to a doctor that would see 3,000 patients and now they're shrinking it. You're comparing it to a doctor that would see 0 patients. So it's not an actual fair comparison, because I would not be practicing medicine today if I did not change my practice model. I just wouldn't have done it. I would found something else to do. I am forced by law to opt out of Medicare when I direct contract with these patients. That was not my decision. That was federal law that required.
Explain that you can't do both.
Right. So when I directly contract with a Medicare beneficiary for services that are covered by Medicare, I have to, by law, opt out. And it's not just opt out in my direct care practice. It is across the board, under everything tied to my NPI. So I can't moonlight as a hospitalist. I can't serve ER shifts. I can't do telemedicine through a traditional teledoc type service because they all bill Medicare. And so that locks me into saying I can only accomplish this panel size by statute. I would love to see that change. I would love to work with you to change that statute, because that has a disproportional impact on rural healthcare. So because if I'm putting a panel of a primary care doctor in rural America, in rural Alaska, rural Utah, I can make a direct primary care practice work and be profitable with 300 to 500 patients. I can't do that with a fee-for-service practice. If I come in with 300 to 500 patients, I'm going to need massive federal subsidies. I'm going to need something to keep that practice afloat, and there's no way you're going to be able to do it. And again, if statute requires me to opt out to do that, I may be the only doctor in your community serving your emergency room. I may be the only doctor that might be able to care for you in the hospital. And statute has required me to opt out because I'm providing more affordable and accessible care. It's important to have the maximum flexibility for physicians to shift to the needs of their community directly and not have that federally dictated. So for example, when we went into COVID, it took 3 months for Medicare to recognize the invention of the telephone, and we're still fighting over whether the telephone is an appropriate access for physicians and whether the federal government should pay for it. Just as recently as 2 weeks ago, we're still trying to decide this. I shifted my practice to a telemedicine on day number 1. When you mentioned the rains falling, when Hurricane Ian tore the roof off of the emergency room next to my office, I didn't need to wait for the insurance companies to convene a new code for me to provide parking lot care for my services. I put a tent in the front of my building. We opened up to all comers, whether they were our patients or not. We provided free care to the community. Why? Because I'm getting paid. I'm getting paid on a subscription basis, and I have the flexibility and ability to provide the services to the care to my community that they need.
Thank you.
Thank you.